First, before I start, I'd like to do the thanks first in case we ran out of time at the end. I just want to thank everybody who's helped with Target and eBug teams and all those involved with developing the Target materials, all the GPs and patients, the Ipsos Mori team who are involved with the surveys. And just to say, I have no conflicts of interest except for those ones where I said that I lead those projects. So what are we going to cover? We're going to cover why GPs prescribe, briefly, why GP staff prescribe antibiotics, the updated UTI guidance and some evidence around that and why we've developed it, and really, most importantly, developing a leaflet that Donna was very much involved with interviews and patients and GPs, staff, about a leaflet to share with patients to help reduce E. coli bacteremia. And then really for you to discuss in groups, so do sit next to somebody you like, so that we can implement the guidance and leaflet and develop your action plans. So, firstly, why do we prescribe or not prescribe? And so Susan Hopkins mentioned another theory this morning, the theory of planned behaviour, but this is so-called the COM-B, which basically behaviour occurs because of some interactions which are going on almost instantaneously with you. And it's your capability of whether you've got the capability to undertake an action. And that may be either your knowledge, confidence, or even the physical ability to do it. Your motivation, whether you're motivated, and that will be affected by your personal attitudes, the subjective norms, what your friends do, what the community does, and the opportunity. So you may be really keen to do it, and you may have all the knowledge and capability, but if you don't have the tools to do it, you can't take it forward. So really, those are the things, all those things I want you to think about all the way through when we're going through the guidance, you know, why we behave like we do, why we do it, and also how we can facilitate the tools we're going to describe. So why do GP staff prescribe antibiotics? If you go and speak to them, they're all really wanting to do the right thing. It's not that they're saying this QP is no good. You know, they're all wanting to do the right thing for their patients. So they're doing it because they believe that it makes symptoms better. Also, in many cases that's what they're doing, but also they're worried about complications. You're going to remember the one patient who is admitted with sepsis and dies following a UTI, rather than the patients, all the hundreds of patients you see with uncomplicated UTI. Also, there's patient pressure. How many of you have had a UTI? Oh, is it only me? Okay, well, obviously, if you've had a UTI, it's very much an underestimated infection. It is really quite nasty. And so, in many cases, you know, there's patient pressure. I've had this before, doctor, please do help me. So what is the evidence that it makes a difference to symptoms? This is a clinical outcomes trial that we were involved with in English general practice using empirical trimethoprim. It was almost 500 women, and they had, it's very important to say, they had 2 or more UTI symptoms, and they had significant bacteriuria. So if you look at these patients, if they had a resistant UTI, it took 7 days for the symptoms to get better, and almost 40% reconsulted in the first week. And many of those had an antibiotic. Most of those had an antibiotic, an extra antibiotic in the first week, compared to somebody with susceptible UTI, which got 4 days to symptom resolution. So very significant difference. So you can see why, if you have a UTI, a definite UTI, it makes a difference to have treatment. The important thing is that these patients have been picked out because they've got greater than 2 UTI symptoms and they have a positive culture. But actually, if you look at the numbers who have a definite UTI, in anybody who is given an antibiotic in general practice, it's actually only 25% in a recent trial, a European trial. The other thing is, I showed you that if you have a resistance, you're less likely to have resolving symptoms. This actually shows the increasing trimethoprim resistance in different age groups in the last 10 years, going from 2006 to 2015. So the most important thing really to look at here is to look at this red one, because these are the over 80-year-olds. And as you can see, resistance is 36% in 2006, and now is 48%. It's very important to note, though, that these are lab specimens, and they're only sent often in more complicated cases. But even so, it would suggest that trimethoprim resistance in this older age group particularly is very significant. And if you can see, with the 65-year-olds over, that again has 30% going up to 34%. So bear this in mind when I come to the guidance. So how do we actually get people to reduce this complication risk? So we need them, that they're worried about. We need them to do a careful clinical assessment, including targeting treatment. So we need to give them the tools to do that. We can get them to use backup delayed antibiotics when it's not appropriate to give antibiotics in the first place, because then we can reduce resistance going forward. And it's very important to give safety netting. So I'm going to move on to the guidance. One of the thing is that antibiotic guidance is the cornerstone of antimicrobial stewardship activities. So I'm going to go through this in detail, so you don't need to be able to read this particular one, because you can if you're at the front, but if you're at the back, you won't be able to. But also, the important thing is that it's on the back of the leaflet that you were given. So actually, it's all there for you, which is why the lights are slightly up. So this is going to give people the knowledge, and if it's made available, the opportunity to prescribe well. So the first thing is, as you can see, it says in comment in the second column there, it talks about who we should be treating, because we shouldn't necessarily be treating all women who present with urinary symptoms. The other thing is, this is often seen as a very quick consultation, and we don't want that to happen. We want these people to be given a good 5 or 10-minute consultation. So all of these things are done. So women with severe or 3 or more symptoms, and if they don't have any vaginal discharge, these women are very likely to have significant bacteriuria, and so you could treat empirically with first-line antibiotics. However, those women with mild or less than 2 symptoms, we could consider pain relief and backup delayed antibiotics. We know from Dutch studies that 55% of women would be happy considering a delayed antibiotic for a UTI, and we've got some data within the English group, which Donna will present. And of those people who have accepted, which is 33%, then it went on to accept a delayed antibiotic, 70% of them had clinical resolution. So those patients, it's really useful. And there have been several studies. There's been one published in the BMJ recently showing that pain relief using non-steroidal anti-inflammatory drugs are really good for the relief of mild symptoms due to UTI. And then often you're told about cloudy urine and not cloudy urine. If you've got cloudy urine, you need to use a dipstick in these patients and see whether they have nitrite, blood, or leukocytes, because that has very good positive predictive value. But you should only be using dipsticks in symptomatic patients. So going on to treatment. So because of that, if you hold that resistance picture into your minds where you've got high levels of resistance, we're now suggesting that in most people you would want to use nitrofurantoin first line. If there's low risk of resistance, then it would be considered you could use a trimethoprim, and that's really in younger women with no other risk factors. Now, obviously, I understand that nitrofurantoin, there may be patients that you can't use nitrofurantoin if the GFR is less than 45 mils per minute. Note that this does not say 60. The guidance has changed recently from the MHRA. They have done a literature review to look at outcomes with the different GFRs, the kidney function. And so if you're up above greater than 45, you're fine to use nitrofurantoin. Lower than that, you should consider pivmecillinam, and if the organism is susceptible, amoxicillin. So what about if you've got multiple or high resistance risks? These are the patients that you would consider fosfomycin. So I gave you the definition of low risk, and these are the risk factors for increased resistance. So if you're a care home resident, if you've had recurrent UTIs, hospitalization, unresolving symptoms, recent travel to a country with increased resistance, especially the Indian subcontinent, Africa, some areas of Eastern Europe and the Middle East. And if they've had a previous UTI resistance to cephalosporins or quinolones, obviously you would need to consider different treatment. So always, if there's risk of resistance, send a urine for culture and susceptibilities. So I was asked to mention recurrent UTIs in non-pregnant, and really what we're wanting to do is for all these patients to be reviewed. It'd be great to do an audit, and I want you to consider that, because first line, we wouldn't necessarily be considering antibiotic prophylaxis. We want to consider simple measures which will be covered in the UTI leaflet: hydration and analgesia. Cranberry products work for some women, so cranberry capsules work, but the evidence is actually lacking, but it's because there are some women who do respond well and some women who don't. So I think you have to discuss that with the patient. Then we're talking about second line standby or post-coital antibiotics. And third line, we're talking about antibiotic prophylaxis with nitrofurantoin, pivmecillinam, or trimetoprim if you've known you've had a culture susceptible. And there's another drug that is worth considering is methenamine if there's no renal or hepatic impairment. There's been quite a few trials now with that. So really, we need to reduce use of these broad spectrum antibiotics for routine use of UTI and increase use of nitrofurantoin in the pivmecillinam. Trimethoprim is still good for lower UTI in younger patients or if you've got known results. And coamoxiclav, really, if you look at all the guidance, we should really only be using it for pyelonephritis in pregnancy, facial cellulitis or prophylaxis post-dog or human bites, or diverticulitis. So Donna's going to take over now and tell you a bit about development of the UTI leaflet that she's been involved with, and then we'll come back and have a little workshop. Just checking how long I'll be, 10 minutes.
Okay, so before we go into detail about the UTI leaflet, there's a few things I wanted to point out first. Everything that we develop in the primary care unit is based on feedback from various target audiences, be that GPs, the patients themselves, schools, whatever. So, and the feedback comes in various formats. So I wanted to give you 3 key points from feedback from a 2014 survey that Cliodna carried out. And the first point is that patients trust their GP. They trust their healthcare provider. You can see that the light green or the dark green, there's a lot of trust there. So it's worth sharing information. It's worth the GPs or the healthcare provider sharing information about the need or not for antibiotics within the consultation. The second key thing is just looking at the percentage of the public in favour of delayed prescriptions. You can see that, again, the green, there's quite a lot in favour of delayed prescriptions, and actually the grey bit don't really mind. They didn't really care. So if you're going to use delayed prescribing, a thorough explanation of the rationale behind the delayed prescribing, because again, going back to key point 1, the patients listen. And then finally, and also how to collect the prescription. And then finally, the last key point is there is a lack of knowledge, however, in the general public about antibiotic resistance. You can see for the first question, bacteria that are resistant to antibiotics spread easily from person to person. It was half and half, really. Only 54% got that answer right. And then the second question, healthy people carry antibiotic-resistant bacteria. There, only 45% got that right. The grey area is they didn't know. So to go on to the leaflet development, I don't want to go into detail here in this forum about how we went about developing the leaflet, because that would take up the whole time. So I just want to give you a brief overview and the key findings. So we carried out in-depth interviews with 20 GPs, and we carried out focus groups with 30 women over 4 focus groups who had previous experience of urinary tract infections, to ask them about their experience, about the experience of the consultation, and to see where the barriers to appropriate prescribing were, so to identify how we could develop an intervention. So unsurprisingly, I think for many of you, the key barrier was time, 10 minutes in a consultation. The GP can't possibly cover everything in that time. The patients didn't feel they could ask a lot of questions in that time. Second, misunderstanding. There was misunderstanding in the patients, as in they had misunderstanding about what a urinary tract infection was, and then misunderstanding from the GP about what the patients actually needed and what they wanted. There was lack of skills on both part, from the GP not probing with the patient, and also from the patient not being able to explain their needs properly. And then the nature of the consults. This came out as quite surprising for me anyway, that a high proportion of these consults are over the phone. So without that face-to-face interaction, some of the patients didn't feel that they could explain themselves very well over the phone, and the GP just had a tick list of things that they questioned. And then finally, history of prescribing. If the patient had previously been prescribed an antibiotic, then they wanted it again in the future. So you all should have a copy of the leaflet in front of you. So I just wanted to go through each of those small sections and explain to you why we have the sections in. So this first section, possible urinary symptoms and other things to consider. This was both the GPs and the patients wanted this in. The GPs were saying it's quite useful for them. For many of the GPs, it was a reminder of things that they may not have asked. And for the patients, it was something for them to look at in the future to go, oh, actually, I only have one of these things. There's no point in going back to the GP. I'll wait. But this was a quote from a GP saying, yeah, you could certainly use the checklist. It's nice in terms of knowing that you're doing it all and covering it all. The outcome, and this plan can be personalised, again, for both the GP and the patient. This is based on guidance, so the GP can look at this, and the GPs felt that this was really useful for them as a backup. So if they had a patient who was really pushing antibiotics and saying, yes, I really want the antibiotics, they could turn around and say, well, actually, this is where you are, and antibiotics are less likely to help. So the GPs felt that was really useful, and the patients as well felt that was useful for looking at and going, well, there's no point in going because this is where I am. This section, the image for patients, this was really introduced at the request of the women. They wanted to be in control. They didn't feel that they had a lot of control over urinary tract infections, but just being able to visualise what it was, where it was, and understand the terminology that the GPs were using really helped them be in control of their symptoms. Self-care and safety netting advice. This was something that the GP said they don't actually do a lot of. They don't give a lot of self-care and safety netting advice because they had no evidence. They didn't feel that a lot of it was evidence. So everything in this leaflet is referenced. If you want those references, please contact us and we can give you a fully referenced version of the leaflet. But the GPs felt this was really useful for them and also give them a safety net to protect themselves and also to protect the women as well and if things got worse. So things like if you have shivering, confused, vomiting, all these things are to come back to see us if any of these happen. And then preventative measures. The women loved this. They were saying that there was lots of things on this that they hadn't even considered. A lot of the women didn't even consider that they could prevent a UTI happening. A lot of the women thought it was just something that happened to them, not that they could do anything about it. So they really liked this. And we had lots and lots of discussions around cranberry products and disagreements between whether they worked or didn't work. But the women very much wanted that on there. They wanted the things on there like, this works for some people, it may not work for you. And then the section on antibiotic resistance. What surprised me was how powerful this section was for the women. When we showed the women this section, I remember one woman in particular who was very adamant that she needed antibiotics. She was just one of those people who needed them. And then she says, do you know what? If I had seen this at the very first consultation, I probably wouldn't have taken them. I would have waited to see if I really needed them. So I thought that was quite a powerful message. But finally, what did the GPs think? Overall, if you want us to prescribe less antibiotics for urinary infection, then this will help us do that. Give us an evidence-based written. You've pointed out that you've only got 2 and it's urinary symptoms. Try and get better on your own. And using this in between would mean that we're actually focusing on the patient a bit more rather than doing it more quickly. So that's just a brief summary of the leaflet and everything that's in there. So I will pass you back to Cliodna now.
Thanks, Donna. That's really useful. So how can we help practices improve their antibiotic prescribing and implement the antibiotic guidance and the leaflets and also meet the QP? So again, I just want to take you back to this because we're going to go into groups to really discuss how we could help to implement the guidance in your CCG. So we've got to think about the capability, the motivation, and the opportunity. And really what's really important that wherever you do any work with any GP practice or anything, that you've got to do action planning with them. So what I don't want you to do is to go home today and go, oh yes, that guidance is great, that leaflet is great, but then nothing happens. So what we'd like to do now is to really discuss in small groups. It doesn't matter whether it's 2, 3, 4, So these, can you read, because I did say, could you move towards the front? Can everybody read what these are? So what we'd like, maybe if we have one side, right, we'll have this side with Elizabeth Beach going back. Put your hand up, Elizabeth Beach. This side going back, talk about implementation of guidance. And this side, talk about implementation of the leaflet. If you get through the questions, and you've all got a little pad in your bags. Do you remember getting a little pad in your bag? So what we'd like you to do is to write down what you're going to do, and we can collect them up. Elizabeth's looking doubtful. You didn't pick up a bag. Okay, so is there anybody who hasn't got a pad? So no excuses for not writing anything down. You've all got a pen that was given to you as well. So, okay. So this is a workshop. You've all got to wake up. You've had lots of... It's after lunch. Okay, maybe we could all stand up for a second and look as though we're going to be active and we're going to get on with this, okay? Enthusiasm is needed here. Okay, guys. Turn around and speak to the person next to you and start your questions. You're going to get the most out of this. What we think would be good is if there's any questions at all, you've got an opportunity to ask us questions. And there's 2 roving mics. Where are the roving mics? There's 2 roving mics. The ladies have jumped up. Has anybody got any questions? Yes, there's one here. There must be more questions. So, yes, so let's start. Any questions about guidance or, what we've recommended? Here's...
Hi there, I'm Karen Homan from Bedfordshire CCG. To encourage GPs to follow the guidance and use the first, second line, etc. choice antibiotics, I think it'd be really helpful if the labs just reported those formulary antibiotics when they report sensitivity data. Locally, we've introduced pivmeselinum as a choice, but our local labs were resistant to actually report it on the reports, so consequently it hasn't been used. And I just wonder whether there's anything that we can do kind of at a national level to encourage the labs to actually report formulary antibiotics.
No, you're absolutely right. That's one of the points I'm going to be coming on to in just a few moments, that absolutely you cannot actually, it's one of the points on here. Where is it? Make sure, no. Number 4, check local laboratory urine antibiotic susceptibility reports follow guidance. Yes, so that's really important, because we've done a study showing that if an antibiotic is reported, GPs will use it. And it's even if an antibiotic report, if it's in alphabetical order, they'll use nitrofurantoin more likely than trimethoprim because it's further above it. But you know what, even if you put it in alphabetical order, something like that, whatever's at the top, they tend to use first. So we do need to have selective antibiotic reporting. I think one of the problems in some of the labs is that if they're still doing disc susceptibility, they can only put 6 discs on a plate. So that may be a problem, but they do need, the CCG needs to talk to them and say, look, they need to do this. Any other questions on the guidance? Yeah, Elizabeth?
Sorry, just to pick up on that point, we've got the same problem in Bath, and our lab is in Bristol, and they won't change to selective reporting. The new PHE lab they're building says they will, but it is really difficult when you're a CCG and you ask, and they say no. Very, we have no
okay, that is something, I'll tell you what, we should discuss this with Phil Howard and the BSAC, the British Society of Antimicrobial Chemotherapy.
Not all labs will be PHE labs, and I don't know if it becomes more difficult when it's not a PHE lab, because, you know, it's easy for me to bash PHE over the head and say help, but it's much harder if it's a local lab. And
so we need to write that down as an action. That's great.
Yeah, and I think Vicky is here as the Chief Scientific Officer's Clinical Fellow, leading on AMR and diagnostics in NHS England, and that's something she may already have on her agenda. My question was, just a question around the guidance, in that we have in Bath and North East Somerset 2 large universities. We have a lot of young university population, and in your discussion with patients, with women, did you find any issues that are specific to university student populations that might influence whether we should be treating them differently from a guidance point of view, or a
the one thing we found was difference is that younger patients very much didn't want their name on the leaflet. So if you remember with the Treat Your Infection leaflet, it has a name on it and it's very much personalised. The younger patients were very unkeen about that, because they probably rightly relate their UTIs to their sexual activity, and therefore they didn't want it known that they had UTIs. So, and we had to word that bit about the sexual activity very carefully as well.
Sarah Mumford, Maidstone, Tunbridge Wells, NHS Trust. I'm a consultant microbiologist. I think, actually, if a letter went out from PHE to all of the microbiologists in the country asking them to change how we report, I don't think that you would have too much problem if you presented them with all of the evidence. I mean, probably a large number of them are here today anyway. I think it's all about who asks to some extent, and if PHE were to put that request in, then I'm sure that many labs would change.
There was another question over here. We'll have 2 more questions and then we'll just sum up probably. Okay, yeah, this lady here.
Hi, my name is Annie Joseph, Microbiology Registrar in Nottingham. I had a question about the preventative measures that are sort of listed.
The what measures?
Preventative measures, conservative measures. Is there good evidence to support that these actually do reduce the incidence of UTI following implementation? Because I've struggled to find evidence to support that. We were discussing, I think it's great that the women felt that was quite empowering, that they had control over their condition, but does it actually make a difference?
Yes, so Donna, we've looked up, everything that we've got is very much evidence-based, isn't it? Because we didn't want to include anything that didn't have an evidence base. So on the website, we've got an evidence-based... Sorry, Donna, do you want to say something? Yeah, okay. Okay, these, so it is very much evidence-based. You can find the references on the website. If you go to the Target Antibiotics website, everything will be there. So these are some of the responses about UTI from the other workshops. So agree the antibiotic choice in the practice that is in line with local guidance. Audit if local guidance choice is in the practice formularies. Make sure locums are aware. We've mentioned the labs. Develop a local UTI template. Consider backup prescription in those with mild symptoms. Always do safety netting, especially in the elderly. Use computer reminders. Load leaflets onto local computer systems. Do a UTI audit, but include dipsticks, recording symptoms and outcome, antibiotic choice, self-care advice, etc. Do the Target UTI webinar, and do the RCGP management of infection online course or something similar. So really, I just wanted to, in the last few moments, really discuss about the Target Antibiotics Toolkit. And you can see the website. It's at the RCGP. If you actually Google Target Antibiotics, it should come up. So the Target Antibiotics Toolkit has all the tools that will help you not only address the UTI QPs, but all the other antibiotic prescribing QPs, and it's completely free. So first of all, what is there? There are learning outcomes, so that will give you capability, they're your GPs and staff, the capability to prescribe correctly. There's the Target Antibiotics presentation, which is based on clinical scenarios and action planning at the end. There's an RCGP online UTI course, which can be done by anyone, again free. And then there's the Target Toolkit online course, so the presentation you can do online. I mentioned the Target webinars. These were extremely popular. We had 1,200 people register for the webinars, and there's a specific one on prescribing in UTI, which covers a lot of the things that we've talked about today, but it also covers prescribing in other areas as well. Again, it's free. You can register for CPD. Motivating is really important, as I said, so getting the whole team involved, so especially with UTI, receptionists are involved, nurses are involved. There's all sorts of different people and healthcare assistants within the GP setting, so you need to find out more about what they're doing. Motivation, so audit materials, and it's important also not to just audit antibiotic advice, but to order self-care advice, backup antibiotics, etc. And there's audit templates for UTI on the Target Antibiotics website. There's also a self-assessment checklist which asks GPs to do a self-assessment, and also commissioners, about what they're doing around antimicrobial stewardship. Opportunity is incredibly important, because if you don't have the materials available, they're not going to work, obviously. And this was discussions about the Treat Your Infection leaflet, actually being able to pass them a piece of paper instead of passing them prescription. It's something to take away. It's good. I think it's helpful because it looks official as well. Another GP said, here's the problem, it's not a click away. And that's what we're doing. We're working with EMIS and all the computer providers to see if we can get the urine tract leaflet on the EMIS website, and we're going to be doing that reasonably quickly. The Treat Your Infection leaflet is already on the website, and there's also a pictorial version, which you can get from the Target Antibiotics website. We discussed the opportunity, so the influence of restricted lab reporting. Just really here, if you look here, this is when a period in a lab where coamoxiclav was reported, and this is the use of coamoxiclav on urines that were reported by the lab. Then Carefalexin was reported, and the use of coamoxiclav went down, and the use of Carefalexin went up. And then coamoxiclav, they went back to coamoxiclav. And there was some persistence of the Carefalexin because they'd started reporting it. So what you report not only affects treatment of UTI, but also influences treatment of other infections. So really, one thing in summary really is that not one single thing works. You need to address both the GP staff, the practice setup, the patients and the public are all important components. So good luck with your antimicrobial stewardship.